Good morning, everyone, and thank you for joining us for today's CME. As you are aware, we will put the feedback link in the chat. So once you do your feedback, we will use that to claim the CME. And remember, today's CME key is stay safe, STAYSAFE. So thank you for welcoming us into your homes, your cars, your morning routine for this morning's CME. And thank you very much for our technical support from Dr. Darren Halliday and the lovely music that brings us to CME. We will have 3 more CMEs left for the year, and the schedule is still the same, second Wednesday and last Friday of the month. That being said, the last Friday of December we will forego because of the holiday season. The topics will be posted in the upcoming weeks for you to see what they are. And so this morning, we have with us a special guest. His name is Dr. Robert Hollis Spencer, and he has been affiliated with the Samaritan's Purse that has been here on the island now for 3 going on 4 weeks. As most of you all may be aware, Samaritan's Purse has joined us in the Bahamas to help with our fight against COVID. So Dr. Robert Hollis Spencer, he was born in Jackson, Mississippi, and Dr. Spencer has a very, very extensive CV, and I will try and do him justice and give you a snapshot. He received his medical education at the University of Mississippi Medical School, and his residency training was done at the University of Mississippi Medical Center and VA Medical Center. His fellowships were done at the Good Samaritan Medical Center. I have a little technical difficulty, 1 minute. At the Good Samaritan Medical Center, and he is specialized in cardiovascular disease, interventional cardiology, and he also did cardiovascular magnetic resonance imaging at Humboldt University in Berlin. He is board certified. He's board certified in internal medicine, cardiovascular disease, cardiovascular magnetic resonance imaging. He has practiced widely at hospitals across the US, public and private, and currently he's practicing missionary medicine from 2007 to present and does world missions with Samaritan's Purse. From 2019, he has been affiliated with Samaritan's Purse Disaster Assistance Response Team, which is their DART team. Amongst his awards and honors, he has received from the American Academy of Family Physician Volunteer Teaching Award at the University of Wisconsin 3 times and at the University of Tennessee twice. He has published in many peer-reviewed journals. He has participated in clinical trials, 12 clinical trials, some of which you may recognize: the ISIS-3 International Study of Infarct Survival 3, the SAVE, which is Survival and Ventricular Enlargement, and the SOLVED, which most of us will know, Studies of Left Ventricular Dysfunction, the treatment study. He has been involved in quite a number of community activities and fundraising, most recently Habitat for Humanity volunteer and builder and donator from 1998 to 2002. He has had mission trips to Zimbabwe, where he was involved with well dedication and school support, well as in building a well for water, school and pastoral support, and hospital support, as well as clinical and community support. He presently is the Bible Study Fellowship Men's Satellite Group leader from 2019 to now, and he has participated in world missions to the Democratic Republic of Congo, and he is presently involved in an ongoing echocardiography telemedicine collaboration with the Democratic Republic of Congo. He has 4 publications in the journals and has published numerous abstract and posters. And he has published a book chapter titled Use of Rhenium 188 Fill Balloons for Inhibition of Coronary Restenosis After PTC, a New Opportunity for Nuclear Medicine. And this was published in 1999. He does have 1 patent to his name, and it's an apparatus and improved method for safety dispensing and delivering liquid radiation for intraluminal radiation therapy. He's actively involved in continuing medical education, and presently he's here in the Bahamas as a provider of missionary medicine and DART services. He was also involved with disaster relief services and the emergency field hospital in Freeport, Bahamas after Dorian in 2019. Thank you for presenting to us today, Dr. Spencer, or as we know you at the Special Pathogens Unit, Dr. Bob, and welcome.
Thank you very much. Thank you for having me here. It's a pleasure to have been in the Bahamas and to both with the hurricane last year and also now with the COVID outbreak. Let me begin by sharing my screen. And so we'll be discussing the Princess Margaret Hospital and the response with a special pathogens unit, and pretty much how we arrived at this concept and treatment process. I have nothing to disclose, and any photos in here that involve patients are used with permission. And as we know, COVID is a dynamic illness. We are learning so much all the time related to COVID. And so the information that I'm presenting is up to date as of today. Just a little bit on the virology of the illness. Sometime in February of this year, the virus actually had a point mutation in it. And we know that that's when the virus actually began in Europe. And with that, we are having a higher infectivity and higher viral loads. But the illness severity has remained the same. But I think what we see from this is more people get infected. Early on in the illness, the concern was how does this virus attack the person? How does it spread? And there was lots of speculation, particularly in the press, and lots of rumors. And so now, after many months of observing how it's actually spread, we know now that it's droplets and contact. And so that's why we wear the mask, and just a simple mask when you're in public is adequate. So the mask is really protecting the people around you. It's not protecting you. So we should always wear a mask when we're in public. And then contact is the other way that it's spread. So these droplets will then end up getting down onto a surface. And if you touch that surface and then touch your face, well, then you've now contaminated yourself. So usually what I say is wash your hands, wear a mask, wash your hands. So you're always washing your hands and you're wearing a mask to protect the people around you and protect yourself. In the hospital environment, most of the people that become infected in the environment, it's because of a breach somewhere in their PPE. Somewhere they touch something and then they touch their face. And what we learned in Italy is most of the times in which healthcare workers became infected at work, it was because they were in the tea room or the break room. So they would be taking care of patients. They would not take off all of their PPE. They would just take off their mask or maybe their gloves. They would go into the break room. They would eat something and then put their gloves and mask back on and go back out into the patient care area. So that was one of the locations where most of the infections occurred. In the household, it's between family members, and it's the husband and wife that are more likely to get infected where they share the same bed than other family members. So this is just to let you have a little bit of idea about where we get infected with it. There are descriptions of people finding COVID in the stool and body fluids and also in animals, but there's really not a lot of description about people becoming infected from these sources. Aerosols, we know that aerosols are only an infectious source if they're nebulized aerosols. So just general population aerosol is not a primary form of people getting infected. So how do we set up in Samaritan's Purse? How did we come about protecting the employees and protecting the community? So we built this off of Ebola. And where we learned from this is with the Ebola outbreak, we designed hospital areas in which the patients were clearly in a defined area, that they were not in an area where the people otherwise were located. So you can see in this snapshot that there are orange fences, and the orange fences divide the patient care areas from the non-patient care areas. So we ended up with what's called a high-risk zone and a low-risk zone. And you really can't cross these zones without going through a specific part of the facility. And so this is our layout when we were in Italy. The Cremona hospital that we were adjacent to was in the upper right corner. And so this is our hospital layout. And down at the bottom, you can see that this is the low risk zone. So we had the administration tents, base supply, medical supply, nurses station were all in a low risk zone. The area that's outlined with the orange is actually the high risk zone. So when you would enter the camp, you would come down this observation corridor and go into the donning area. And in the donning area, you would put on your PPE, and then you would enter the high risk zone. And so you could be in this high risk zone and go to any of the patient care areas, but when you left, you had to leave through the doffing area. And we would be in this area for hours at a time, taking care of patients, and everything that we needed was contained within this zone. If we needed extra supplies, someone on the outside could pass that material, whether it be IV supplies or paperwork or whatever, across into the zone, and we would be able to collect it and use it. But this is taken from the Ebola Treatment Center concept, so that we have clearly defined areas that were safe to work and areas that were high risk to work. When we were inside the tents, and this is the intensive care unit for Italy, you can see this yellow tube, which is our airflow. So we had air that would be heated or cooled and pumped into the tent. And it's not in the picture, but in the right side down, just past this bed to the right, was the exhaust. So we had airflow that was constantly running through the tent. And in our intensive care unit, we had 10 patients on ventilators and 2 extra beds for step down. And in this area, we were able to treat patients, including using nebulizers, every 1 to 4 hours on every patient in there. And this environment was safe for us to work using the PPE that we're using even in Princess Margaret and the treatment center that we have set up now, the SPU. So we would stay in here for hours at a time treating these patients, and the environment was safe to us to work in. Eventually in Italy, we developed a area which we could have high flow nasal oxygen. using the same concept. The airflow comes in and there's an exhaust vent on the other side, and we were able to treat patients with high flow oxygen in a similar environment. Later in the year, I was deployed to the Navajo Indian Reservation in New Mexico in the United States, and we were inside of a hospital. And so inside of the hospital, we were in their recovery room. So the double doors behind us actually lead to the operating room. These doors were sealed, and behind me are doors that led to an outdoor, rather to a corridor to the rest of the hospital. So inside of this recovery room, we made this the COVID care unit. And over on the left-hand side is the nurses station. And I'll show you a photo of that in a moment. But once we were donned in our attire, this photo is before we actually were seeing patients. But we would don our attire and we could be in this area seeing these patients, and you could be in there for whatever length of time you needed to be to take care of the patients. And then you could doff and go out and go into the clean zone. In the, let's see if I can go to the next slide. In the nurses' care area, this is the nurses' station. And we were able to put plastic around the nurses' station. And it was sealed at the top and sealed at the bottom. And we had windows that were cut into it. And this window material is the same stuff like would be in a convertible car. So it was that kind of plastic like in a convertible that you could actually see through there and see what was going on. But in the nurses' station, you could just be wearing typical scrub clothing and a simple mask because that area was a low risk zone. And through on the other side was a high risk zone where the patients were being cared for. And so now we move to the Princess Margaret Hospital, and I'm going to show you two different concepts that we've implemented and been able to work with Princess Margaret and put together. So this is the special pathogens unit that's set up in the parking lot. And over on the right-hand side, the patients enter the gate here and are placed in one of these three tents. And this area is a high-risk zone, and there is a corridor here where the patients can go to the bathroom, but the patients can be anywhere in this area. There's a clear divider here that divides the high-risk zone from the low-risk zone. So the employees enter on the left side and come into the changing area, change into scrubs, and then go through the donning area where they don the PPE, enter the patient care area, provide the patient care, and then exit through the doffing area, and then they will go and change back into the clothes they wore to work, leaving their scrubs here, and then exit the facility. So this gives us a clear area of high risk and low risk, and it protects the staff in that manner while still providing patient care. And then, so this is one of the tents, actually before patients were in it. Each bed has electricity and oxygen, so each bed has an oxygen port so they can have oxygen delivery. The nurses' care area is up in this part of the tent, and then this you can see outside goes into the exit. Outside of the tents, this is what I talk about where there's a clearly defined barrier between high risk and low risk. The patient care area is on the right, and anything that we have that needs to be passed to the patient, such as their meals or their medications, actually is placed on one of these shuffle boards and pushed across to the staff that's on the inside. And this distance is a greater distance than you can reach. So you can't touch someone's hands that are between these two areas. And that's deliberate to keep people from just handing stuff across where you could accidentally contaminate each other. And so inside Princess Margaret, we've taken that same concept similar to what was in the Navajo Hospital. So this is the private medical ward. The image on the right is before, and the image on the left, the image on the left is before, the image on the right is after. And you don't see the plastic that we had within the Navajo facility, but you see the tape on the floor. And the tape on the floor is to protect you. And yes, you can just walk across it because there's not a physical barrier, but you have to understand protecting yourself and protecting your coworkers is of paramount importance. And in the middle, we've delineated the low risk zone, which includes the break room, the nurses station, the offices, and the high risk zone, which is the patient care areas. So this concept is only as good as the employees' initiative and drive to protect themselves, their family, their country, and their coworkers. So if you come into this, you don in this room, and then you step across the line into the high risk zone. After you provide patient care, you come to the doffing area, take off your PPE, and step across into the low risk zone. So we don't actually have a physical barrier, but there is a barrier just the same that protects you. And when you go to the Med Surge 2, it's the same concept. You have the nursing area and the dining room, which is low risk, and then the patient care areas, which are high risk, with a border down the middle that clearly defines the zoning, and there's signage on the walls that instructs you which zone you should be in with which PPE. And so when we look at the PPE, going back to Ebola, we have, with Ebola, we have a very high level of PPE with the plastic, the gowns, and we actually spray off with bleach water. We don't need that with COVID. So in COVID, we can use the semi-permeable gown with the face shield and the gloves. And you can sometimes improvise. The one here on the right is what we ended up using in Navajo when we ran out of PPE. So these are those heavy surgical waterproof gowns and a shower cap. So you use what you have whenever you can get to the point to where you're scrounging for different items. And so in the hot zone or the high risk zone, we want you to have shoes that you don't wear to your house in the evening. So bring a pair of old shoes and keep those at the hospital and change into them. If you're going to be in the um, if you're going to be in the excuse me, if you're going to be in the high risk zone, we also want you to wear scrubs that you're not taking home. And then the IPC team has gone through the rest of the items on this slide. And this is our slide back from Italy. We have a one-way. You go one way into the high-risk zone, and this is on the left-hand side is where we're going into the high-risk zone. It's a one-way trip. If you go into the high-risk zone, you stay there. And the other image is coming out in the doffing. When you come back out, you don't turn around and go back in. These are hard set rules that you have to obey. So enough on protecting ourselves. Let's shift a little bit and we'll go into the treatment itself of COVID. These are the risk factors that puts people in a high risk. And in my experience, I think the one that's most prevalent in almost all of the patients that have been the most critically ill is obesity. So I think that we need to pay attention to our family members and our friends and neighbors and look at these high risk. And if you are around people, be sure that you're protecting the vulnerable people in society as well as your coworkers. In the laboratory features, I know that we have patients that come to Princess Margaret and they're evaluated and they're screened, and those COVID tests sometimes take 24 hours or so before they come back. But if you're just getting their other labs back before the COVID test comes in, many times the feature that I've seen that's most prevalent is the lymphopenia. So if you see lymphopenia on their initial lab works, I think even before the COVID test comes back, you can say this patient probably has COVID. Chest x-ray and imaging. This film shows a patient that has many different features of COVID. And so in some areas, you see this paucity of the COVID changes. And then you see the other areas where there's the changes that are common for COVID. But this patient unfortunately has other imaging features. On the patient's left side, there's the changes in the far part of the lung field, and this patient actually had aspergillus. And the patient, if you look around the trachea, actually has tracheal damage. So the trachea there is enlarged from tracheomalacia. So the thing that we really want to look at when we're looking at the chest x-ray is whether or not this patient has COVID changes. But the other thing that I look for frequently in the patient's chest x-ray is their volume status. And I'll touch on that in a minute. The list of medications, we see this long list of medications on the right-hand side of the screen. I've had experience in having patients on all of those in trials, and pretty much none of them impact the patient's care. The remdesivir, the convalescent plasma, and the steroids are kind of the ones that people are headed towards now. The remdesivir now has mixed reviews. Initial results suggested it was going to be a cure-all. More results say that it's probably not. It has to be given early. The convalescent plasma is only as good as the titers of the plasma. It's not available in many places, so we have to take that one also with availability. And the one that we are using and seeing the most of is the steroids. Anytime that a patient is being treated with oxygen, they should be placed on steroids, and the protocols are listed. 6 milligrams of dexamethasone, PO or IV, for 10 days when they start oxygen. But if they get discharged sooner than 10 days, they can discontinue it. The other one that is very important is anticoagulation. We know that patients with COVID have an increased risk of thrombus, and this is not just macrothrombi like DVTs and pulmonary emboli. It's also microvascular thrombi, which can affect many organ systems. And so the typical DVT prophylactic dose of the enoxaparin many times is not effective, and they will many times require an escalated dose. And this is where we get into the societies that are out there are not backing a higher dose of prophylactic anticoagulation, but there are trials ongoing, and there's many university settings around the world that have escalated the dose of prophylactic enoxaparin. And two of the regimens that are out there that are kind of widely known is that if you're under 60 kilograms, it's 40 milligrams once a day, 60 to 80 kilograms, 60 milligrams once a day, over 80 kilograms, 40 milligrams twice a day of the enoxaparin, and an alternate regimen is 0.5 milligrams per kilogram twice a day of enoxaparin. So it depends on how much enoxaparin you have available in your stockpile as to how you dispense with that treatment. And more importantly, if any patient has a change in their status in which you think that they are at risk of having a DVT or a pulmonary embolus, or if they previously had a DVT or pulmonary embolus, they probably should be on the milligram per kilogram twice a day of enoxaparin. Of course, you'd have to dose adjust that if they have renal insufficiency. And back in the early aspects of COVID, there was concern that non-steroidal anti-inflammatory drugs or the ACE inhibitors and ARBs could actually provoke cytokine storm. So we were withholding these drugs in patients, but we now know that that's not a problem. So these patients can receive those medications. Respiratory treatment. Our goal for discharge is patients to have a resting O2 saturation of 93% or greater for 24 hours prior to discharge. And within the hospital setting, we are shooting for an O2 sat at rest between 88 and 92% or above. So we really want to give them oxygen to maintain a sat somewhere in the 93% range. But if they drift down to the 88 to 92, we allow that passive hypoxemia, or the happy hypoxemia as some people refer to it, because if you give them more oxygen than they need, it actually can be detrimental to the lungs. And certainly SATs, pushing oxygen to SATs greater than 96% has clearly been shown to be harmful to the patient. So we only want to give them the oxygen that they need with the least flow rate method that is effective. Proning, if the patients have an increasing amount of oxygen requirements, self-proning in the wards is certainly encouraged. And when the patients are prone, we typically are trying to get them to prone for 3 hours at a time. But many times the patients can't do that because of pain. Back pain is the biggest problem. And the thing you have to remember about is with self-proning, it is not durable. So if they prone for 3 hours, they might get an hour of benefit, and sometimes that hour of benefit gets shorter and doesn't last, and then they have to prone again. If the patients are mechanically ventilated and you're proning, those proning sessions are typically 18 hours at a time. So that's when the proning actually works. Proning for shorter lengths of time really is not that effective. And we'll talk about nebulizers. If you have a safe environment, such as a legacy, you can use nebulizers, but otherwise on the general ward, we don't recommend nebulizers. When we were in the Navajo, we actually took the hood that you use to test a N95 mask, so it's what they call a fit test hood. We would actually put that over the patient and let the patient nebulize. And as you can see by the nurse demonstrating on the other photo, where the hood would actually come down over their clothing, much of the nebulized material would actually rest and come to rest on the patient's clothing and not be atomized into the environment. Again, this is something that could be done in a safe environment for the staff. And with the treatment, with the respiratory treatment, what we're really trying to do is mobilize secretions. We really want to get the patients to cough up those secretions. We don't want to suppress their respiratory drive. Anything we can do to get that patient to cough and expectorate the secretions is valuable. The secretions that the patients have with COVID are very thick. They are hard to expectorate, and if they're left in the lungs, they actually block the bronchial tubes and the patients will decline. If the patients go on to requiring mechanical ventilation, invasive ventilation, I've found two different subsets of patients. There's the one that has a typical ARDS pattern, which comes from the alveolar damage related to the COVID attacking the alveolar surface of the lungs. And these patients, their lungs, they have fluid buildup in their alveolar space, and they behave like a typical ARDS patient. And in ARDS, you typically are using a higher level of PEEP, and you're using a lower tidal volume. But you also see patients in which you look at their chest x-rays, and the chest x-ray just really doesn't look that bad. And you wonder, why is this patient requiring so much oxygen to the point that they're requiring mechanical ventilation? And from autopsy studies, we now know that these patients have microvascular thrombi. You can do a CT pulmonary embolus study, and there's no big PE, but they behave like they have a thrombus. And these patients are having microvascular thrombi. So in these patients, you use the typical low PEEP table and the typical tidal volumes you would have of any other patient requiring mechanical ventilation. And this is where I also would look at the patient's chest x-ray and look at their volume status. So many of these patients also will end up having congestive heart failure type pattern on their chest x-ray. And we know that patients with COVID, and in some reports, it's up to 30% of the patients will also have a cardiomyopathy. So if you treat the patient like ARDS and you have a low amount of intravascular fluid, you're also indirectly treating their congestive failure. And with all of these patients that are being treated with invasive mechanical ventilation, if you have a safe protocol, and this is not something that I would recommend unless you've really done this a lot, is proning the patients, because proning can be very dangerous for the patients if it's not done correctly and well. But outside of that, you looking at your paralytics and your sedations, we really try not to paralyze the patients unless they require it to meet their oxygen demands. We do sedate them, but we try not to paralyze if at all possible. Um, and with any time that patients are being mechanically ventilated, you want to work towards moving towards tracheostomy based on the current hospital standards if they've been mechanically ventilated, certainly for more than 7 days, but in some facilities, that's 3 to 5 days. And we would fall back on whatever the policy is of the facility. And this is what I talk about with the secretions. The gloved hand is showing the secretions that were removed from a patient, and then the other is the endotracheal tube. And what we found is that in many patients, the endotracheal tube would clog up with these secretions, even though we were lavaging the patient every hour and suctioning the patient. These secretions would build up inside of the endotracheal tube to the point that we could no longer mechanically ventilate the patient, and we would have to exchange endotracheal tubes about every 3 days. We already talked about the anticoagulants. We withhold antibiotics in the patients unless we see a rising lactate, procalcitonin, CRP, or some other indicator of an active bacterial infection. When these patients first show up, yes, they're febrile. Yes, they have changes on their chest x-rays. But these, unless you see an elevated white count, this is a viral process, and antibiotics really don't have a place in the patients early on. But after the patients have been in the healthcare environment for some length of time, then you worry about hospital-acquired infections, and that's when you need to start assessing the patients and trying to determine if they've defervesced from when they first arrived and now they're starting to have fevers again. You have to look for a secondary bacterial infection. When we talk about fluids, because it's an ARDS pattern and it's not a sepsis pattern of a bacterial sepsis, we don't use the sepsis protocol. We actually treat these patients like ARDS. And so in an ARDS pattern, you're really trying to keep the intravascular volume low. And if you need to, in the intensive care setting, we actually would prefer to use some norepinephrine to support their blood pressures over giving them intravascular volume. And when these patients are on the ventilator, we assess them daily, and we actually would use furosemide to pull their volumes down, measuring their urinary outputs and making sure that they were adequate. We'd follow their BUN and creatinines. We'd look at their neck veins. We'd look at their chest x-ray. We would look at their skin turgor, their mucous membranes. We would do other things to assess their volume status in the ICU and try not to give them too much fluids. That being said, nutrition is key. These patients need to be fed. From the first day, they need nutritional support, whether that be in the ICU getting tube feedings or on the wards getting good caloric intake. We do know that COVID causes a hyperglycemia in people that are not diabetic. And this hyperglycemia typically will resolve at or before discharge. So when they first come in and you see that hyperglycemia, we know that if you overshoot them with insulin, they actually will have a lot of hypoglycemia. So we let there be a little bit of passive hyperglycemia and not try for tight control early in the illness. And you just kind of watch that and treat that cautiously. And in many patients, it does go away. If they are previously diabetic, they will have a little bit of out of control sugars initially, but then again, they come back under control. Antipyretics, we now know that we can safely use any antipyretic. It is a multi-organ system disease. It's not just a lung problem. Like I mentioned before, many of them will have a myocarditis. You're indirectly treating that when you treat the rest of the illness by keeping their volumes low. They have a hepatitis, so you have to be careful when you're giving them medications. Where is that medicine cleared? How is it excreted? If you're using paracetamol, you have to make sure that you don't cause toxicity. They get a nephritis. They end up with with kidney injury. And also with the myositis, they can end up with kidney injury from that. You have to be very careful with all the organ systems that any therapy that you're delivering doesn't end up with toxicity from your medications. The vasculitis is rampant. The immune response to COVID goes through the interleukins. Interleukin 6 is one of the most potent derangers of the vascular system. And when I was looking at intravascular radiation therapy for all my research in the past, interleukin 6 is the one agent that we know really disrupts the vascular system. And that's where you end up with all the clotting. So the repair process and the response causes this intense vasculitis, and that's why you see young people that will have strokes and clots and arterial clots. So you really have to keep that in mind when you're treating these patients. The other piece down at the bottom is the infections. You have to look at the nosocomial infections late in the illness, and you have to treat what you typically see in your facility as infections. And then there's the aspergillus, which in our ICU, and this is reported this is not something related to a contaminated ICU because that's been investigated, but aspergillus occurs in up to 10% of the patients in the ICU setting, and that can be seen as early as day 6 of the illness. So the pearls, we've kind of gone through many of these things, the least amount of paralytics. Certainly you want to only treat antibiotics when they have a clearly defined infection. You want to have a low patient to nurse ratio because that's going to improve your patient care. If you're giving IV fluids and if you need to give IV fluids, we prefer that you give prescribed boluses and not constant infusions. And this just gets to be the nature of the beast. When we're treating patients with IV fluids, many times we end up starting an IV and you don't really realize, but 5 days later, they've gotten way too much fluid. We want them to stay physically active. We want the patients to rehab. Discharge criteria, which are posted in the hospitals. And then we'll go some into the nursing perspectives. We really want the patients to have really good oral care. We want to make sure if they have endotracheal tubes that we check their pressures and that those devices are secured. We want the nursing to be able to help us understand how that patient is breathing. Are they working hard to breathe? What is their hourly or their every 4 hours intake? Are they, where's their I's and O's? These are critically important in these patients. And we need to be monitoring their vital signs to see exactly where their saturations are going. And this needs to be done frequently. If they're ventilated, we need to be recording their ventilator settings every hour so that we can understand what the patient is, where that patient is going and where they're trending. When those patients are in the intensive care unit, they're going to be getting nebulizer treatments. We have to be careful that sometimes they'll end up requiring chest tubes. We need those patients mobilized. They need to be sitting up in the bed. Their head of the bed needs to be elevated. We actually took our patients that were on the ventilator, we took them outside. We transport the patients outside in Italy so they could actually get sunshine. And if they're bedridden, we've got to be sure that they're turned every 2 hours. We do everything we can to make sure that we don't have ventilator-associated pneumonias by keeping the head of the bed up and suctioning deep in the back of the throat. We want to make sure that they don't get urinary tract infections with catheters. So if their catheter can be removed, that catheter is taken out as soon as possible. And if they have central lines, we make sure that those dressings are changed according to hospital policies and guidelines so that we don't end up with catheter-related infections. And anytime that catheter is accessed, we use sterile technique. And we make sure that the patients are getting prophylaxis for secondary hospital adventures. They get their DVT and GI prophylaxis, pressure ulcer prophylaxis, and we also try to keep their oriented to days and nights to prevent the delirium. So this is where we were, where patients were actually getting rehab, taking them outside for some daytime sunshine, keeping them oriented. And at this point, I'll be happy to take any questions that you may have.
Thank you very much, Dr. Spencer, for that presentation. So you said earlier that most of the transmission of infections happened in tea rooms and when people were doffing. In terms of your unit, have you had any issues with exposures?
We, in our unit, we had one person in Italy that had an exposure, and that was a breach of a PPE that was not addressed as soon as it should have retrospectively.
Okay. And so you have managed ICU patients in your tents?
Yes, we have.
Okay.
We had, I think we had a total of 30 patients that went through our ICU.
Okay. And what were some of the significant challenges you have experienced since managing COVID with your Samaritan's Purse tent model?
I think the largest challenge early on in Italy was just the overrunning of the adjacent healthcare facility. They had 450 beds for COVID patients, and they had 540 patients. And I think the biggest challenge that we ran into was getting patients tracheostomies soon enough. They had 3 patients in every operating room, and they had patients 2 deep in their recovery room. So they physically could not perform tracheostomies soon enough, and we had patients that had complications related to that. And that was the one that hurt the most.
Okay. And so we have a question from Dr. Yashika Simo, and she says, good morning, excellent presentation. Thank you. And do you have any data or observations specific to pediatrics?
No, we've not treated pediatrics in our facilities. So that's one group that we've not taken care of.
Okay, and Chelsea Brown says, awesome presentation, Dr. Spencer. And from Dr. Avril, wonderful presentation. Can you speak on weaning patients off oxygen therapy, any do's and don'ts?
Yes, I think when you're weaning, we try to wean as quickly as possible. So all day and all night, the nursing staff have parameters, and they're trying to wean the patients all the time. And the do is to mobilize the patient and encourage that patient to be physically active, upright, and that's the biggest do. The patient's got to be engaged. The don't is that patient can't just lie supine in the bed. If they lie there and if you can't get them to cough and to breathe, they will not survive.
Okay, thank you. And what, from Chelsea Brown, what are the average mortality rates of ventilated COVID patients in your ICU?
We had a 44% survival in our ICU. So that was back in Italy. And the patients that we received, when we first arrived in Italy, they had been treating COVID for 30 days. We received 10 of their patients. Many of those patients had already been intubated for a month. So we received patients that had been mechanically ventilated for 30 days when we first arrived. They had not had a single survival in 30 days. So we thought we at a 44% survival rate was pretty good.
Certainly an improvement, yes. So Dr. Delisha Wood, your Bahamian colleague, says, wonderful presentation, Dr. Bob, and thank you. And so, Dr. Bob, so you spoke about Samaritan's Purse and your involvement with Samaritan's Purse was mentioned in your introduction. How can a physician in the Bahamas get involved with Samaritan's Purse? Are there any barriers related to where the physician might have been trained?
No, there are no barriers. You go to SamaritansPurse.org, and there's a link up at the top that says what we do, and you go down, follow that link to submit an application. And so there's a link on there where you can actually apply. We have providers, nurses, and physicians all over the world. So we have really, it's a worldwide organization.
Thank you. And so it was reported that low vitamin D has shown to be associated with poor outcomes. Are vitamin D levels checked in patients, and is there a role to give vitamin D?
Yes, I've been in many locations and we've given a lot of vitamin D, but and it is true that there's an association with low vitamin D and poor outcomes. But to date, there are no studies that show administering vitamin D after you contracted COVID changes outcomes. And because vitamin D is a liver type processed agent, you have to be careful about giving vitamin D because we don't know if it actually will have an adverse outcome in patients that already have hepatic insufficiency. So I would wait for the clinical trials.
Okay, thank you. And Dr. Santita Belgrave, great presentation. Thank you for sharing your experience and the updated approach to managing patients with COVID. In regards to patients on discharge, is there any benefit to continuing aspirin given the increased risk of thrombosis?
In patients that are at risk of vascular disease, such as your diabetic population or people with underlying vascular disease, certainly aspirin has a role. There are no studies at this point that I'm aware of that say that putting people on aspirin across the board changes post-discharge outcomes. So there again, we're waiting for the studies and the data to come out.
Thank you. And good morning. Excellent presentation, easy to follow and comprehensive. How long does it take to assemble and disassemble the IPC setup?
It usually takes us 48 hours to set up an emergency hospital. So somewhere around 48 hours, and then it's usually an extra day to get the logistics down of moving patients. And then taking it down takes about 4 or 5 days. It takes longer because you have to decontaminate everything.
Okay, and from your other SPU colleague, Dr. Ejoma, good morning, Dr. Bob, great presentation. If IV fluid is needed, is there a preference in terms of type, and if so, why?
With your IV fluids, we typically would use lactated ringers because the lactated ringers, if you're resuscitating patients, does not cause an additional hyperchloremic acidosis. And these patients are already prone to acidosis, and if you make them more acidotic, then you increase the work of breathing. So LR is a preferred fluid over saline or D5 by itself.
Okay, and from Dr. Alvary, Hannah, good morning. Thank you for your service. Have you encountered any challenges with patients arriving or leaving the tent facilities by ambulance, particularly IPC?
I think that there's always a challenge when people enter into the facility because sometimes, especially with the ambulance crews, they don't understand the clear demarcation, but we work through that. So it's typically not a huge challenge. It just takes reinforcement so that we make sure that everybody stays safe. But anytime that you approach through that gate, there's always challenges.
Okay, and from our Chief of Staff, Dr. Caroline Burnett, thank you, Dr. Bob. I enjoyed rounding with you and learned a lot. Bless you and the team for the help that you have provided to the Bahamas, and I'm sure we all feel the same way. So thank you very much, Dr. Bob, to you and your team for reaching out to us in the Bahamas. Dr. Andrea Griffith, with respect to the utilization of PPEs in PMH, has Samaritan's Purse made any recommendations?
Yes, there are IPC teams present that are going around to the different areas to instruct in IPC. So this is an ongoing process. And I know that also that's being taught through Zoom to the sister islands. So that education is being disseminated widely. And we're using the WHO guidelines for PPE utilization.
Okay, thank you. And we have one final question before, actually, we have a couple more questions. I see Dr. Ramphal has said, have you encountered any unique features, issues with our patients here in the Bahamas?
And I think that the population here is really reflecting the population that I've seen in all the other locations. We initially thought it was a male-dominated illness, but we now know that it's about the same. It's 50-50. And so I think the population here is exactly the same as in other populations. I do see that in Italy and in Navajo, and I'm sure that there's a good amount of that here, is that populations that are very communal, where families get together frequently and they have close relationships in their household, that you will end up with more disease being spread in communities.
Thank you. And from Chrissy Brown, knowing what we know about the spread of COVID-19, is it preferable to nurse these patients in a unit separate and apart from the regular hospital setting?
I think any time that you can nurse these patients individually, it reduces the overall exposure to everyone in the facility. So it's like any other infectious disease. If you put them together, then you require less staff, less PPE to manage the patients, and people can concentrate, and the knowledge base will go up the more you take care of the patients. So you'll end up with staff that become better trained and equipped to manage the patients. So overall, it's a better outcome for the patients.
Okay. And Dr. Varunda would like to know, she says, thank you very much. Enjoyed the presentation. Did you come across with any studies or experience with respect to mucus plug aspiration through bronchoscopy?
We would really have loved to have a bronchoscope, but we did not have one when we were in Italy. I'm not aware of any studies, but I do know that that would have been a huge blessing to have had that type of equipment to manage those patients.
Okay, thank you. And Dr. Conville Brown, our cardiologist, would like to say fantastic presentation from a cardiology colleague.
Thanks.
And Sister Valerie Miller, excellent presentation, Dr. Bob. Thank you very much for the assistance from Samaritan's Purse. The initiative received very positive reviews. And Chrissy Brown would just like you to explain a little bit more about the comorbidities and how it affects survival rates of patients who have contracted COVID-19, please.
The comorbidities makes I think those patients become more susceptible to becoming more critically ill, which is not good English, sorry. But what you see is they exacerbate their underlying illnesses. And I think it allows them to, the disease to go further and affect them. It's interesting that patients that are immunosuppressed don't get as much COVID storm because they don't mount as much of an immune response. So if you're already immunosuppressed, usually your disease is less. But if you're not suppressed, well then the people that have underlying heart disease, well then they're more likely to have heart failure and heart rhythm issues. The people with underlying lung disease have a tougher time with their lungs and the kidneys. So if an organ is already under stress because of an underlying disease, because of the widespread effect of this disease, it's just more devastating to them. Any organ system that already was at risk is just more affected.
Thank you very much. And we have another question from Dr. Chalika Chisholm. Is the individual room model, like in GPC or Legacy, preferred to open floor model as in your tents?
I don't think that the GPC model has some inherent flaws as far as how you can isolate high risk and low risk. But the private medical would be a better place to put patients that are like the PUI, the patients under investigation. So if you have a PUI patient, it's better to keep them isolated by themselves until you declare them one way or the other and not put them into the open room. But once the patient is positive, co-housing them in an open area is just as reasonable as a private room. So it really doesn't make any difference at that point. It's only your PUIs that you want to isolate. So that if you don't want to have a PUI next to someone that's positive if the PUI ends up negative, because then he has a nosocomial infection.
Okay, and I think this is probably going to be our last question. Good morning, everyone. Great presentation, Dr. Bob. What has been your experience with NOACs in the treatment of outpatients with significantly elevated D-dimer levels?
Well, I don't have a personal experience with the NOACs, but certainly what we had available in Italy, we did not have them. So those patients actually went home with a full dose subcutaneous heparin, which was fairly difficult to manage. So the NOACs certainly would be a preferable agent because you don't have to monitor. And the difficulty with patients being discharged on anticoagulation is the monitoring. So then you have to have that patient go somewhere and get blood drawn, and that exposes everyone along the path. So a NOAC would certainly be better.
Okay, thank you. And thank you for a comprehensive presentation, Dr. Sybil Suraj, our ENT consultant. With respect to tracheostomies in these patients, were they done percutaneously or open? What would be your recommendation to minimize aerosolization, hence transmission to staff?
The tracheostomies that we had were open because that's what they had at the time in Italy. They had run out of percutaneous trachs. They didn't have any more, so we were using open trachs. And they were done in the operating room using the full PPE that you would typically wear in any other environment with the face shield and the gowns like you'd have in the operating room. But that we did not, and they did not use the Tyvek suits with the full hood and everything. That was not used. And even when we would intubate patients in the tents, when we would exchange their endotracheal tubes, we would wear the typical clothing that you saw us wearing in the tents in the photos.
Well, thank you very much, Dr. Bob, for that presentation. Clearly, it generated a lot of interest and answered a lot of questions. And thank you again to you and your team for joining us and helping out in the Bahamas.
It's been a pleasure, and I am grateful that we had the opportunity to meet and that we were invited to come assist during this time of need.
Thank you, and everyone have a good day. And please remember, flu shots are available every Friday at the CCB staff entrance. Please call to make your appointment at EHS to get your flu shot, and encourage all patients, colleagues, and family members to get your flu shots as well. We have 2 CMEs left for the year, Friday the 27th of November and Wednesday the 9th of December. So you will be seeing the notices for those. Everyone have a great day. And I see the feedback link has been put in the chat. The enrollment key is stay safe. Thank you very, very much, Dr. Halliday, for all the technical support. And there's one last question, Dr. Bob, and seeing as you're a cardiologist, what is the chance of myocarditis?
The data is not really widespread, but it's about, in early reports, early in the illness, is about 30% were felt to have myocarditis. And that's where you see the troponins elevated to a mild degree. And if the troponins are just mildly elevated, you assume it's myocarditis. Only if you had something that was more dramatic would you say, myocardial infarction. So the low level of troponins, we just always assume is from myocarditis.
Well, thank you very much. And Dr. Catherine Conliffe, thank you for this presentation and your service, Dr. Bob and Samaritan's Purse. So everyone, have a great day.